dislocation of hip joint. Now, if you remember, we have already done dislocation of shoulder joint. So a bit of similarity between these two joints. So what is the similarity between hip joint and shoulder joint? Anyone?
Sir, both are ball and socket joint.
Very good. Excellent answer. Both are ball and socket joint. Now, what is the difference between hip joint and shoulder joint regarding stability? Yes?
Joint cavity.
Good. So which joint is more stable? Which joint is more stable?
The hip joint is more stable.
Hip joint is most
stable.
Exactly. Hip joint is more stable because of the anatomical peculiarity. Remember, shoulder joint, the head of the humerus is very big in comparison to the glenoid fossa, whereas this acetabulum is a deep cavity and head of the femur is nicely fitting there, and it is surrounded by a strong capsule as well as some ligaments. So hip joint dislocation is not very common in clinical practice. Having said that, if the injury is a massive one, okay, a big type of injury, like a motor vehicle collision, road traffic accident, those type of injury, then hip can be dislocated as well. Sometimes it is simple dislocation, sometimes it is a complex dislocation, means it is associated with some fracture in that area. Now, let's start with a bit of anatomy of hip joint. See here. The hip joint is ball and socket joint. It's a type of synovial joint. So it allows a lot of, enjoys a lot of movement, I should say. A lot of movements are possible in any type of synovial joint, especially ball and socket type of joint. Okay. So it is formed by two bones. Okay. This is head of the femur and the upper one is acetabular cavity, or you can simply say acetabulum. It's a part of the pelvic bone. This is the neck of the femur. Okay, this is the intertrochanteric area. Here is the greater trochanter, here is the lesser trochanter, and this is the shaft. Now this hip joint is surrounded by the capsule. In the last class, I clearly told you where is the attachment of the capsule. Towards the pelvic bone, it attaches on the margin of acetabulum, and towards the femur, it attaches anteriorly on the intertrochanteric crest, okay, intertrochanteric line, sorry, and posteriorly a bit superior to the intertrochanteric crest. That is the attachment of capsule of the hip joint. Now it is reinforced by many powerful ligaments, okay, iliofemoral ligament, ischiofemoral ligament, and pubofemoral ligament. These are reinforcing the capsule of the hip joint so that this hip joint is very stable there. We need a lot of power or energy to displace it. Now see that, okay, another picture, a little bit of a better one than before. This is the acetabulum, and here is a femoral head. The femoral head is very smooth anatomical structure because of the attachment of cartilage there. Now there are three types of hip dislocation. Posterior dislocation is the most common one, followed by anterior dislocation and central dislocation. Posterior, anterior, and central. Now in this class we'll talk all of these in detail. Now see there, dislocation of the hip joint can be of three types. Anterior dislocation, just around 10 to 15%. Posterior dislocation is the most common one, around 70%, and rest, okay, is central dislocation. Now, what do you mean by this, isn't it? That's what you need to understand. What is anterior dislocation? Can anyone tell me how I give the name in case of dislocation? Yes?
Sir, the head of
displacement of distal fragment.
femoral head.
Exactly. Exactly.
Anterior
By the
to
way,
the
trauma is
anterior.
happening like from the posterior to anterior or anterior to posterior.
Now, I already got the answer, from the students. Very good. I always look at the distal bone. Where is this distal bone present in comparison to the proximal? Always look at the distal. In this case, head of the femur is the distal one. So where is head of the femur located in comparison to acetabulum? If it is present anterior to the acetabulum, we call it anterior dislocation. If it is present posterior to the acetabulum, posterior dislocation. And central means it is a complicated type of dislocation now. There is a fracture of the acetabular cavity and the head of the femur is, going through that acetabular roof with fracture. This is known as central dislocation. And that's a very complicated one. Now, after knowing this, remember one very important point. That's what we need to do all the time in the hospital. If somebody comes with dislocation of the hip joint, reduce hip dislocation as soon as possible. Okay, as soon as possible, ideally within 6 hours, to decrease the risk of vascular necrosis of the femoral head. Because the vascularity of femoral head may be compromised if we reduce it later than 6 hours. So that's why dislocations are considered orthopedic emergency. Just like management of a compound or open fracture, dislocations are also, should be attended quickly or immediately. Now look at this mechanism of injury. Okay, see here, this person suffers an accident here. Okay, so the knee is struck on the dashboard. See there is a collision. Okay, and the knee is struck here, so a lot of force is transmitted through the shaft of the femur and goes towards the pelvic area, and during this time hip dislocation can occur quite easily. Now, these are the different mechanism of dislocation. All of these are severe type of injury. You can clearly see here. Okay, it is a hit by a car there. Okay, there is a collision, and it is again, see there, compressed in between the two vehicles. So all of these are severe type of injury. So we understand hip joint is not easy to dislocate. We need a massive amount of force to dislocate it. See there, again the same thing. This is these are the different schematic diagram which will make you understand easily. This is hip joint, okay, dislocated hip. See, this is a femoral head, acetabulum, and femoral head is coming out of the acetabular cavity completely. Then only we call it dislocation. If a bit of part is attached there, we call it subluxation. Now, how to diagnose it? Okay, how to diagnose hip dislocation? Now, in 99% of the cases, it is diagnosed clinically. But having said that, we always take help of X-ray. Always. X-ray is done in 100% of the cases. Regarding the symptoms of dislocation of hip joint, there is history of trauma. There's a massive amount of trauma. Remember this, like road traffic accident, RTA, fall from a considerable height in flex knee, mine accident or air crash, or any such type of severe injury. Pain, there's a lot of pain there. There is deformity of the limb, deformity because the head of the femur has come out of the acetabulum, and there is restricted movement of the hip. These are classical symptoms. What are the signs now? So let me explain this sign because these are quite important if you want to diagnose it. Okay, now see here, there is deformity of the limb which I can see in the patient. And what type of deformity is more common? Shortening of the limb, hip is flexed, adducted, and internally rotated. Posterior dislocation of the hip is most common one. So these are commonly seen in posterior dislocation. The limb is short. Okay, it is adducted and internally rotated. A hard mass due to displaced head is felt in the gluteal region. And this is nothing but a head of the femur, which is dislocated. There is a restricted movement of the hip. I always tell this point in the patient. When we ask the patient, to move the joint by themselves, this is known as active movement. But when we ask the patient just to relax and we move the joint, this is called passive movement. Both are restricted in case of hip joint dislocation. there may be impairment of function of sciatic nerve. Now, we all know sciatic nerve, okay, is the biggest nerve in our body. It is the thickest nerve in our body. So what is the origin of sciatic nerve? Anyone? From where it comes?
Lumbosacral plexus.
Good. That answer is enough. Lumbosacral plexus. Lumbosacral plexus. Okay. L4, L5, S1, S2, S3. These are the origin of sciatic nerve. Sciatic nerve is divided into two parts or two divisions. And what are those two divisions of sciatic nerve? Yes.
Common peroneal nerve and tibial nerve.
Excellent. Common peroneal nerve. Common peroneal nerve and tibial nerve. Very good. But remember, in the thigh, okay, both of those nerves are together. They are together. When it reaches in the upper part of the popliteal fossa, then only it is divided into two branches. That sciatic nerve can be damaged during hip joint dislocation. So we need to examine the neurological function later on. Some of the vascular changes may occur because of dislocation of the hip joint. The blood vessels which are nearby may be damaged. Femoral artery is one of them. So we need to palpate the distal pulses. One of them is arteria dorsalis pedis and another is a posterior tibial artery. So if they are absent or if they are feeble in comparison to the other side, then we know blood vessels might have been damaged. At the same time, do general examination of the patient to see other bony injury. Now remember, this patient has suffered big type of injury or massive amount of injury. So we have to find out whether there are other fractures in the body or not, like fracture patella and head of the femur, supracondylar fracture, even chest and pelvic fracture as well. So this we always do, this is a part of general examination. Let's move on. Now, just now I told you we have to do this neurovascular examination all the time in any serious type of fracture or dislocation. So how to do that? These are the signs of sciatic nerve injury, and these include loss of sensation in posterior leg and foot, loss of dorsiflexion. If common peroneal nerve is damaged, we cannot dorsiflex the ankle. And if tibial nerve is damaged, we cannot plantar flex the ankle. Okay, never forget this. If you just remember this much, you can diagnose if a sciatic nerve is injured or not. Dorsiflexion is the function of common peroneal nerve because it supplies the anterior compartment of the leg and lateral compartment of the leg with its two branches, superficial peroneal nerve and deep peroneal nerve, whereas the whole posterior compartment is supplied by tibial nerve. That's why if there is no dorsiflexion, that means the common peroneal nerve is damaged. Okay, remember this. There is loss of deep tendon reflexes at the ankle because S1 and S2 are responsible for that. Okay, this is the root value of the ankle jerk. So ankle jerk may be absent. What are the signs of femoral nerve injury now? Sometimes even femoral nerve can be damaged. Now, regarding the root value of the femoral nerve, it is L2, L3, and L4. L2, L3, and L4. Okay, and femoral nerve is mainly, supplying which muscle? Anyone? Which muscles are supplied by femoral nerve? I want quick answer here.
Quadriceps muscle.
Quadriceps. Anterior compartment.
Absolutely, quadriceps muscle. Very good answer. Quadriceps muscle. Okay, so there are four muscles which are present in the anterior compartment of the thigh. They are supplied by femoral nerve. Now, there is loss of sensation over the thigh because it is also a sensory nerve. And see there, weakness of the quadriceps muscle. And what happened if quadriceps muscle are weak? Which function is lost now? What is the function of quadriceps femoris muscle? Yes.
Extension of knee.
Excellent. Extension of the knee. Very good. I'm sure every student knows this. Extension of the knee is done by quadriceps femoris muscle. So if they are weak, if they are paralyzed because of femoral nerve injury, knee cannot be extended in the patient. And loss of deep tendon reflex at knee because the root value is L3 and L4. Even L2 plays a role there, okay? So these are some of the important points regarding neurovascular exam. Now with this, let's enter into the different types of hip dislocation. It starts with anterior. In anterior dislocation of the hip, the femoral head is displaced inferomedially in relation to the acetabulum, or in other words, it is present anterior to the acetabulum. It is the result of forced hip abduction. Very powerful force is necessary for this type of dislocation, and hip should be struck in the position of abduction. Now look at this picture. Okay, see there, it is written H. This is the head of the femur, A is acetabulum. So there is no contact between head of the femur and acetabulum. So this is dislocation. That's the first thing, Now it is clear cut, picture here of the X-ray. The head is present anterior to the acetabulum and inferior as well. So this is anterior type of hip dislocation. Another picture of anterior hip dislocation. Here is the head of the femur, you can see here, and this is acetabular cavity. See this, here is the acetabulum. There's no contact at all. So this is dislocation. Another picture, this is acetabulum, here is head of the femur. So it is completely separated from that, and it is present antero-inferiorly. Okay, see there, this is even the better one, anterior dislocation. Now, regarding the mechanism of anterior dislocation, we just now talked about it. There should be serious type of injury in the abduction position of the hip. Anterior hip capsule is torn or avulsed from the attached area, and femoral head is levered out anteriorly. This is the anterior dislocation. Now, how it looks, okay, what is the position? This is important point. The hip is minimally flexed, externally rotated, and markedly abducted. Minimally flexed, externally rotated, and markedly abducted. This is abduction of the hip. And we all know what is abduction, isn't it? Let me hear that answer once again. What is abduction? Yes?
Moving away from the body.
Away from the midline.
Going laterally.
Exactly. Moving away from the body, away from the midline, or laterally. All are absolutely correct answer. So that is called abduction. So you can clearly see, look at this joint, or this leg. See here, it is abducted, and this is external rotated. Okay, we always have to see the knee here. Where is the knee facing? It is facing a little bit outwards. So external rotation. Now, with this discussion, let's talk about posterior dislocation of the hip. So posterior dislocation, you can clearly see in this picture. Look, where is the head of the femur? Head of the femur is present posterior to the acetabulum. Okay, though it is a schematic diagram, but a very good one for the understanding. And this is the position of that leg in posterior dislocation. Please compare between anterior dislocation and the posterior dislocation quickly, okay? This is the important question which is asked in the exam. The hip is flexed, it is internally rotated, and it is adducted. Whereas in anterior dislocation, it is minimally flexed. So flexion is a common point in both, but there is external rotation and abduction. These two are different now. So by looking carefully or examining carefully in the patient, will tell us what type of dislocation is this, and X-ray is always there for us. X-ray will give you the confirmed diagnosis. Now this is posterior hip dislocation. So this is the most frequent type of hip dislocation in clinical practice. And what is the mechanism now? Severe force is necessary. Okay, in which position? when the hip is flexed and adducted. When the hip is flexed and adducted. So then posterior hip dislocation occurs. For example, injury into dashboard in motor vehicle collision, the picture which you saw before. Regarding the clinical features, there is pain, there is deformity, there is decreased range of motion, all those things. Sometimes there may be neurovascular bundle damage also. So leg is short, it is adducted, and it is internally rotated. So many times we have repeated this, but these are quite important one. So let me underline them once again. The limb is shortened, adducted, and internally rotated. Okay, let's move on. Now let's see some of the X-rays here, so that you can understand, very easily. This head of the femur is present posterior to the acetabulum. Now, how I know this is posterior? That question must be coming in your mind, okay? Because only a part of the X-ray is shown here. Now look at this area. Look at this area. What is this area called? Yes. What is this area? Anybody? What is this bone first? Which bone is this?
pelvic bone.
Exactly. This is pelvic bone. So which part of the pelvic bone is this? Ilium, isn't it? Iliac bone. Ilium. Okay, ilium. Now, if you talk about the anatomy of the ilium, the superficial part, this one is called iliac crest. Okay, this is called posterior superior iliac crest, posterior inferior iliac crest. So definitely this part is posterior and head is present right there. So this is the posterior dislocation. You know, this is the way we identify. That's what I'm explaining right now. So 90% of the hip dislocations are posterior. Sometimes, according to the different textbook, this percentage may vary. But just remember, posterior dislocations of the hip are the most common one. In this injury, the head of the femur is displaced superolaterally in relation to the acetabulum. Okay, superolaterally, and it goes posteriorly. It is often associated with posterior acetabular rim fracture because of the force or power which is involved in the fracture mechanism. And the common mechanism of injury is hitting the dashboard in a motor vehicle collision or accident. Now see here, so these are the different X-rays where hip dislocated posteriorly. So this is posterior dislocation of the hip. Now, once again, okay, that classical deformity, which is such an important point from the MCQ point of view, or even from the Viva point of view. This is anterior dislocation, and here is the posterior one. You can clearly see anterior dislocation is externally rotated, a bit of flexion, okay, and abduction. In the posterior dislocation, internal rotation, adduction, and flexion. So this is the classical deformity. This is another picture which is telling us the head of the femur is going backward. This is acetabulum. Now, this is the another picture which is showing the same thing. Now, they are the muscles which are associated, or the muscles are present in that area. See that? This is known as iliopsoas. Iliacus and psoas major combination is known as iliopsoas, and these are the adductor muscles. So because of this, there is a classical displacement after the dislocation of the hip. The flexion which we were talking is caused by iliopsoas, okay, and this adduction is caused by this adductor group of muscles. Now, can you name those adductor group of muscles? Which are the name of adductor group of muscles there? It's a little bit anatomy question. Yes.
Adductor magnus longus brevis.
Excellent. Very good. Adductor longus, adductor brevis, and adductor magnus. Okay, these are called adductor. And one more question. Which nerve is supplying these muscles? Which nerve? Which nerve? Yes, who can answer this?
Obturator nerve.
Obturator nerve. Excellent. Obturator nerve. Very good. So femoral nerve supplies the anterior compartment of the thigh, mainly the quadriceps. Obturator nerve supplies this adductor. Okay, that's the one. Now, one more dislocation is left for us to discuss, that is central dislocation. Now, central dislocation is a complicated type of dislocation because it is always a fracture dislocation. There is a fracture of the mid area of the acetabulum. Acetabulum has to force, head of the femur has to force its way through the acetabulum after fracturing it. So just think about a large amount of energy or force is necessary here. Now look at this beautiful X-ray. Okay, see here was, okay, the place for acetabulum. Now the head of the femur is forcing its way after fracturing this acetabular roof, and the head is present here now. So this is a clear-cut picture of central hip dislocation. This is a very complicated one, and it is quite rare also in clinical practice. Now, what investigation we need for the diagnosis of dislocation of hip joint? X-ray. Okay, there are different types of X-ray. If you are not satisfied with only AP view and oblique view, you can take some other view also. And CT scan is also done, especially if you think there is a fracture dislocation. CT scan is always better than the ordinary X-ray. Close reduction under conscious sedation is the one which we employ for the reduction of hip dislocation. That means we give some analgesics or some sedative drugs to the patient and then do it, okay, with certain procedure. GA is given only if there are associated femoral neck fracture. ORIF is done if unstable intra-articular fragments or posterior wall fracture is present. Otherwise, ORIF is not necessary. Post-reduction CT or X-ray is always taken just to make sure whether your treatment is successful or not, or whether any leftover fracture is there or not. And then after, okay, the reduction, put in traction for 4 to 6 weeks, especially if the reduction is instability occurs because of severe damage to the capsule or ligaments. After 4 weeks of this traction, non-weight bearing walking is allowed, and after 12 weeks, weight bearing walking is allowed. Usually, though it is written as an unstable, reduction, we only do this, but after the reduction of hip dislocation, okay, for a few weeks, the patient is immobilized just to make sure the torn, ligaments or damaged capsule will heal in time. Okay. Now see there is a process or a method just to reduce the hip dislocation back into its normal position. This is known as Rochester method. Rochester method. You don't need to know in detail because you are not going to do all this procedure on your own. If somebody asks you this question, then you can say like this. Okay, you can go through this. There are different types of movement we do, and ultimately we make sure that head is gone back into the acetabulum. Now, what are the indications for open reduction? We don't go for this, remember? Usually we go for close reduction under conscious sedation. But if we need to go, what are the indications? Let's talk about it. Irreducible dislocation, which occurs in approximately 10% of all dislocation, especially the central type. Persistent instability of the joint following the reduction. Persistent instability, okay, of the joint following reduction, like fracture dislocation of the posterior acetabulum, fracture of the femoral head or shaft, and neurovascular deficit that occur after close reduction. All of these are complicated type of situation, so we need to go for open reduction. Now, this is the last part of this discussion. What are the complications of hip dislocation? Most of these we have already discussed before. a vascular necrosis of head of the femur tops the list because it is quite common to occur, especially after 6 hours. If the treatment is done, already the damage has been done to the head, that is avascular necrosis. Now, if we do not detect this avascular necrosis in time and patient is not treated in time, what are the late complication of this? Yes, what can happen later on?
Deformity.
Good. And one more, deformity and osteoarthritis. Very good. Deformity and osteoarthritis. Okay, so that's why it should be detected and treated in time. Sciatic nerve palsy, stiffness of the hip joint, delayed union, especially in case of fracture, recurrent dislocation, if there are severe damage done to the ligaments and the capsule, osteoarthritis, and myositis ossificans. This is called heterotopic calcification, means in the surroundings of tissue, there is formation of the bone, okay? So this can also be considered as one of the complications in this condition. Now, a bit of summary. Hip dislocation is not that very common in clinical practice because it is a very stable type of joint. Though it is a ball and socket type of synovial joint, it is very stable one. We need a large amount of force to displace it. There are 3 types. Posterior is the most common one, followed by anterior and the central. Okay. Now the signs and symptoms are just like any other type of dislocation or fracture. Quite easy. Patient cannot move that limb. There is deformity development, pain. Okay. There may be neurovascular bundle damage as well. There are typical deformity in case of hip dislocation. Posterior is the most common one, so you always include that first. Okay, so in posterior dislocation, let me ask that question once again before I move to the other topic. What is the deformity in posterior dislocation of the hip? How the limb looks like? Yes?
Abducted.
Adducted,
Left adducted.
Internally rotated.
internally
Rotated.
rotated, and slight flexed. Adduction, internal rotation, and slight flexion, and there is shortening of the limb as well. These all are important, deformity in hip dislocation. Okay, and diagnosis is clinical most of the time, but you always take the help of X-ray or CT scan. And treatment is reduction as soon as possible within 6 hours to avoid the complication. Sometimes even open reduction is necessary, and some of the complication can occur like this if the treatment is not done in time. So with this, let me stop this topic.